Welcome to another study group RN section. This is Nurse Mia. Today we cover Chapter 5, Palliative Care, End of Life Care outline. If you like the way I study, you can have the PDF down below. Introduction to Palliative and End of Care. The goal is to improve quality of life for patients with serious or life-limiting illnesses. Focus, symptoms relief, psychosocial support, spiritual care, not limited to terminal care. Settings, hospital, home, long-term care, hospice, outpatient. Chapter is categorized in 3 sections. Number 1, historical background. Number 2, palliative care, which has 8 domains. And third is ethical implication and moral distress, nurse self-care. Introduction. Palliative care improve quality of life for patients and families facing life-threatening illnesses. Focus on prevention and relief of suffering through early identification, assessment and treatment of pain and other issues. Can be provided alongside curative treatments or in non-curative stages. Types of hospice care are 4 categories. Hospice care at home, primary model care provided at patient residence. The second type is continuous hospice care, intensive symptoms management provided at home, 24/7 care. Number 3, inpatient hospice care for patients needing hospital-level symptom control. Number 4, respite care is a short-term relief for caregivers' temporary inpatient stay. So, hospice care from the keywords was terminal ill patients, life expectancy less than 6 months, and it focused on comfort, symptoms, management, and emotional, spiritual support. Versus palliative care, which focus on improving quality of life for patients with serious life-limiting illnesses and can be provided alongside curative treatment. Number 2, it's palliative care versus hospice care. Palliative care, we said, for any stages, with or without curative intent. Hospice, it's for end of life only, usually less than 6 months, and no curative treatment. It's just pain management. And here we have palliative care offered at any stages, can be combined with curative treatment, focus on symptoms control and decision making, and covered by many insurance plans. Versus hospice care, again 6 months, less than 6 months, is no longer treatment, no longer pursued, and focus on comfort and quality of life, which is pain management, and covered by Medicare, Medicaid under hospice benefit. 2 core components of palliative care. Interdisciplinary team is like doctors, RNs, or LVNs, social workers, chaplains. The symptom management is the pain, dyspnea, nausea, anxiety. Advanced care planning is living well, healthcare proxy, code status, emotional, spiritual support includes family and caregivers. Communication is clarifying goals of care, realistic expectations. The 8 domains of quality palliative care, which said there are 8. So the number 1 domain is the structure and process of care. Defines the palliative care team's roles and communication, includes care coordination across all settings, ongoing care plan reviews, ensure alignment with goals and values. So we know that the care follows the patient across healthcare settings, and hospice education provided when death is expected within a year. Yes, the second domain is physical aspects of care, which here we have like assessment, treatment, and documentation of symptoms, which is pain, opioids, non-opioids, complementary therapies. About dyspnea, which is breathlessness, oxygen therapy, morphine, positioning. And then we have constipation, nausea, vomiting, medication, and dietary adjustments. So that can be into physical aspects of care. Which pharmacologic and non-pharmacologic therapy are both used. Non-pharmacological is like repositioning, all complementary treatments. The number 3 domain is psychological and psychiatric care. Common psychological symptoms are anxiety, depression, delirium. So regular assessment and documentation of mental health status is very important. So we need to do the screening for depression, anxiety, grief, and coping distress. Referral of mental health or spiritual support as needed. Emotional care extends to families, members, and caregivers. Domain number 4, social aspects of care, which is between family and caregiver, conferences to discuss goals of care, prognosis, advance or care planning, and assessment of social support, which is the legal and financial concern, caregiver availability and coping, access to medication, equipment, and services. We have to encourage caregiver inclusion in care planning, include support for legal, financial, and practical concerns. Domain number 5, it's about spiritual, religious, and existential aspect of care, which is respecting patients' religious, spiritual belief in end-of-life care, integrating faith-based practice into care planning like prayer, rituals. Chaplains or spiritual care advisor are part of the team. support, meaning, faith, forgiveness, hope, and legacy. So then domain number 6 is cultural aspect of care. Here we have to assess cultural belief regarding healthcare decision and information disclosure, dietary preferences and religious practices, death, suffering, and grief traditions, burial and funeral services, where we have to honor their beliefs, values, and any tradition. Everybody's it's different. We need to adopt communication and care plans to cultural preferences, and to avoid stereotyping, nurses must ask, not assume. Domain number 7, care of the intermittently dying, which can be the symptom management, pain and discomfort, which are opioids, non-pharmacological intervention. Then we have respiratory distress, which are oxygen, positioning, medication, delirium, which is calm environment, symptom control. Also, we need to have family support to encourage family participation in care, to provide private time for saying goodbye. The post-mortem care after death, body preparation, family support. And we have domain number 8, ethical and legal aspect of care, which ensure informed consent, autonomy, and respect for decision, covers the advanced directives, the PLOS, DNR, and decision-making capacity. Nurses advocate for the patient expressed wishes, especially if conflicts arise. So this is domain number 8. We need to assess for decision-making capacity, identify a surrogate decision maker, ensure full disclosure of diagnostic and prognosis, respect the patient's right to refuse treatment. And these are all 8 domains from all domains of palliative care. Now we move to the next part, which is ethical implication and moral distress. Which are the nurse self-care, the nurse's legal and ethical responsibilities, is to respecting autonomy, dignity, and culturally competent care. Then we have ensuring informed consent, accurate documentation, recognizing and reporting signs of family distress of ethical conflict. And here also it's post-mortem care goal and the steps, confirm the death per institutional policy. Every facility has their own policy. Remove lines, tubes, clear body, close eyes and mouth, support family in rituals, prayer, burying, say goodbyes, complex documentation and legal forms, prepare body for morgue funeral transfer. Usually the hospice, they are more prepared on this section, and they offer for the nurses a training and how to do it. So the moral distress for the nurses is to emotional struggle when unable to provide care aligned with personal professional values. The self-care for nurses also practices to prevent burnout and compassion fatigue, rituals after patient death, a moment of silence for the deceased, sending bereavement card to the family. Nursing care at end of life, physical symptoms of approaching death. We have like signs and symptoms which the nurses should be very familiarized. They have nursing priorities, which is pain and symptom control, the mouth and skin care, family communication and presence, cultural, spiritual consideration, promoting dignity and a peaceful environment. Here we have the advanced care planning, which is the definition process of discussing future care preferences, includes advanced directives, living will, plus form, DNR orders. The nurse role is to educate, assess, understanding, advocate for patients' wishes. Moral distress and moral injury. Moral distress is knowing the right action but unable to act due to constraints. Moral injury is long-term psychological harm after witnessing or participating in action that violate personal ethics, impact, burnout, emotional withdrawal, PTSD symptoms. Nursing focus is to the briefing, ethic consultation, institutional support. Here we have the chapter summary, takeaways. We have like about, let's say, 10 key points of the chapter 5 that we do a summary. Once again, palliative care improves quality of life at any stage of serious illnesses and is not limited to the dying phase. Hospice care is reserved for patients within less than 6 months to live, focused purely on comfort. The advanced care planning helps to ensure care aligns with the patient goals and legal rights. Nurses must assess, understanding, and support those decisions. Moral distress injuries in nurses must be recognized and addressed to avoid burnout and emotional harm. End-of-life care requires attention to symptoms control, dignity, communication, and family inclusion. Post-mortem care preserves dignity, supports families, and includes documentation, cultural respect, and preparation for the body. And here we have the family involvement and support are crucial in care decision and bereavement. Cultural consideration influence how Death, suffering, and grief are viewed. Ethical issues include informed consent, decision-making capacity, and the right to refuse treatment. Nurses must engage in self-care and ethical reflection to prevent moral distress. The last one is post-mortem care, includes preparing the body, supporting family members, and providing resources for bereavement. The end of chapter. Thank you. And thanks for watching. I hope it was helpful. Like and subscribe for future chapters. Comment if the PDF was helpful or any other opinions. Bye from now.